All right, so let's get chapter 5 started here. Let me share my screen. And chapter 5 is on health and prevention. It is the same length in PowerPoint slides as chapter 4. Hopefully I'll make this one just a little bit shorter. Okay. This is, I especially like the quote here, "Do not try to live forever, you will not succeed," by George Bernard Shaw. For those that I've had in classes before, I've asked that question: if you could live to be 100, would you want to? If you could live to be 110, would you want to? A lot of times everybody says, well, it really just depends on what my quality of life is. And isn't that the answer for just about anything? So looking at the chapter, we're going to be dealing a lot with health. Obviously, last chapter we did with physical changes. So key concepts that we need to address with health and prevention is not just necessarily looking at our health from the aspect of whether we are disease-free or absence of disease, but also what are some of the things that we're able to do on our own, and how can we continue to live that life of quality that we want? We don't normally want to look at, I want quantity over quality, do we? We want quality over quantity, or a good balance of both. And when I discuss activities of daily living, those are ADLs, and the types of activities of daily living are going to be those things that we can do ourselves for ourselves, that we don't necessarily need to have somebody help us with these things. If we do need help, then we are receiving assistance with those ADLs. And at that point in time, we might be looking at living someplace where we are receiving that assistance. So an assisted living facility, living at home with our caregiver, could be our spouse or a significant other. It could be living in the home of our children, if we have children who are acting as our caregivers. But the activities of daily living, bathing, dressing, transferring, meaning I can get up from my chair and go to do something, or I can transfer to my chair, I can transfer from my bed up and go about my business, using the bathroom, toileting, and eating. All of those things we have to do ourselves, right? Nobody can do that for us. We can get assistance, but the basic function of it is we have to do it ourselves. Whereas instrumental activities of daily living are going to be IADLs. That's things like using the phone. I don't have to use the phone if I don't want to. I can ask somebody to use the phone for me. I don't have to do my own shopping. I could have somebody do it for me. I just had my Kroger click list picked up this morning. That's a choice, obviously, but click list is something that I can have somebody go do my shopping for me. And if I can't drive myself, somebody could go and pick it up for me. Or there are also delivery services. 50 North has a grocery delivery service, has had. I'm not certain if they still are doing that with COVID. I think they are. But obviously with more social distancing. Preparing meals. I could have somebody prepare my meals for me. I could get Meals on Wheels or mobile meals. I could have family members who prepare those meals for me. Completing household tasks, doing my laundry, or using public or private transportation, taking my medications. Now, obviously, I'm the only person who can swallow my medications, but somebody could help me with remembering to take those medications or giving me those medications. If I can't, maybe I need to have some kind of injections. Somebody could come and help me with those. And also handling our finances. So ADLs are those that are personal to us that we need to do in order to eat, excrete, don't mean to make that rhyme, but get dressed, things like that. Instrumental activities of daily living are balancing the checkbook, shopping, doing our laundry, doing household chores, talking to somebody on the phone, those types of activities. Behavioral risk factors, as we said in our chapter 4, diet, exercise, and don't smoke, right? Here you go again. Here it is, behavioral risk factors for chronic diseases in adulthood. We smoke. it's going to lead to problems. If we are physically inactive, if we have an inadequate diet or an unhealthy diet, and if we're using alcohol unhealthfully, not in a healthy manner, we might see raised blood pressure. We might see raised blood sugar or raised blood lipids, i.e. cholesterol, and obesity, which can then lead to cardiovascular disease, can lead to cancer, can lead to diabetes, can lead to chronic respiratory disease. The percentage of individuals with chronic conditions by age group, I want you to pay most attention to the fact that arthritis across the board is the most common chronic condition amongst all age groups, okay? So here you see heart disease, 12.1%, 45 to 64, all the way up to 41.6% in the 85 and over. Stroke, 2.9% for 45 to 64 to 12.7% for 85 and over, but arthritis, almost 30% of individuals 45 to 64 suffer from arthritis. Over half of the adult population over the age of 85 suffer from chronic condition of arthritis. We look at coronary heart disease, heart attack, cancer, all cancers, and diabetes. You notice that dementia is not listed here. However, that we will talk about. Okay. So arthritis is going to be the most common chronic condition amongst all of the age groups. Diseases within the cardiovascular system, we have cardiac and cerebrovascular conditions, the incidents that they occur, the risk factors that go along with that, and how do we prevent that. So cardiac conditions are going to be these two that I'm not going to butcher, but think of hardening of the arteries or plaques developing in the arteries, coronary heart disease, hypertension, high blood pressure, or congestive heart failure. All of these things are going to be those cardiac and cerebrovascular conditions. Also stroke and mini stroke. So a transient ischemic attack, a TIA, okay? So some individuals can be younger and have a TIA. And that, I believe the risk of having a stroke after that is around for like 2 years after a TIA, and then after that, then the risk decreases. But the greatest risk is within 24 to 48 hours of that TIA showing up. And anybody can have a TIA, anybody can have a stroke, okay? All right, the incidence that we do see heart disease and stroke, 24% of the United States deaths in 2013 were attributed to heart disease. We also have about 31% of the deaths accounting for the age 65 and over. So 24% is all age groups. 31% of the deaths among those over 65 and over are due to heart and cardiovascular disease. 31% of all the deaths around the world as well. So it's an issue, right? It's highest in these areas. 25th is where the United States falls, at least in 2013, and this is in the WHO nations. So yeah, okay. And then this is just a map that shows you where stroke-related deaths actually occur. Hancock County, I don't think I can make this, so if I use my little cursor, Hancock County is about here. So that is in the average annual rates is about per 100,000, 66 to 74 per 100,000 deaths for strokes. So, but look at this, and we have to ask, what is it? Why do we see these darker areas? If anybody has a guess on that, I'm going to give you about 2 seconds to think about it, but I want you to think of socioeconomic status as it relates to health. Okay. Very urban areas, urban areas, possibly lower socioeconomic status in some of these areas. I'm not saying everybody's all lower socioeconomic status, but think about it. So this is southeastern Ohio. This is West Virginia. This is the eastern part of Kentucky. And then obviously the western part of Kentucky, my in-laws are actually like right around in here. So think about it in that sense, that if we see these larger, darker areas, does it necessarily run to risk factors, socioeconomic status, health prevalence, health life expectancy, health literacy? But here, look, we've got like a lot of darker up here too. Okay, so so yeah, just some food for thought on that. So how do we prevent heart disease and strokes? Well, we look at 3 key factors, 2 of which we've already talked about ad nauseum: diet and exercise. But the third being prescriptions, and that's those statins. These are the things that are going to go in there and help with that heart disease. It could be lowering cholesterol. It could be, I mean, basically that's what statins are there for, is to address your cholesterol, to address your artery health. Okay, so statins, exercise, and diet, the top 3 focuses on the factors of prevention of heart disease and strokes. Risk factors of prevention for cancer, as well as the treatments, are concerned. Some risk factors are things that we can control, some of them we can't. 2 are, well, actually, about 4 things on here are things that we might have a little bit more control over, exposure to the sun being one. However, for those individuals who might be out in the sun due to that is their occupational status, is being outside all the time, then they really don't have a lot of control over that, do they? They can use things like sunblock with, something in there to help with the UV ray protection. But today we are on an increased risk for individuals as far as the air quality is concerned. It's because of the ozone layer. In some areas, there's more of an increased risk of higher exposure to UV rays or the UV rays of sunlight. So that's an issue. Cigarette smoking, 80 to 90% of lung cancer deaths are due to smoking. Unfortunately, there are going to be those individuals who do not touch a cigarette in their lives, and they end up with lung cancer. So it can happen anyway, but 80 to 90% of those with lung cancer, the deaths are due to smoking. Diet, intake of red meat has been shown to be related to colon cancer. However, there are other studies that say, no, red meat is good for you. For a long period of time, the American Medical Association and doctors were all saying, oh no, eat red meat. The redder, the better. So that's why you saw a lot of individuals developing tastes for rare meat. Because the American Medical Association, they wouldn't lie, and the red meat is good. Red meat also being just where it's coming from, right? So red meat being bison, cattle, not just cow, cattle, beef. But then we have the white meats, so turkey, pork, things like that. Environmental toxins, we might have exposure at work to certain toxins that can be associated with increased cancer risk. There are those individuals who live in areas where there have been toxins dumped in water supply systems for a number of years, and they didn't know about it until people started getting sick. So there might be clusters of cancer cases in certain areas. So these are all different risk factors that we would look at for cancer. Treatment, obviously, is going to be the best form is prevention. Okay, prevention is always the best form of treatment for everything. The fact that we have screening guidelines that have come so far in the progression of improvement, breast cancer, it has pretty much, not that it's been eradicated, but for the most part, the survivability of breast cancer, as long as it is detected quickly, that is in those screening guidelines, then the survivability of it is much greater if they catch it early, obviously, right? And that really is can be said for a lot of things, but screening for breast cancer, think about when mammograms are expected. It used to be 35 and then every year after 35. But now they're saying women should start having mammograms if there is no family history of breast cancer, should start having mammograms at 50. So because of those screening guidelines and those screening opportunities and prevention and awareness around breast cancer, that has actually come leaps and bounds. Different options of how to treat cancer, obviously surgery, radiation, chemotherapy, and then some biological therapy. Just depends on the type and the type of cancer. I'm no MD, so this is where I leave this. Okay. Osteoarthritis, osteoporosis. Osteoarthritis is going to be a degenerative joint disease. We might see the joints deteriorating because of overuse, because of obesity, or because of injury. And this is where I was talking about a hip replacement, where if you have a sports injury or you just have an injury, mine was due to congenital defect. The treatments that I received, pain management, I would take ibuprofen. Ibuprofen, I would take 1,000 milligrams of ibuprofen every single time. And it just didn't touch it. And my general practitioner always starts off very conservatively. And he said, well, let's go ahead and let's do a steroid injection. Sometimes that helps. So that's another pain management technique. Well, the only thing that helped me was to have a hip replaced. And when I went to my osteo, my osteo, I'm over here making up people. My orthoped surgeon about this, he said, you are about 4 years after the use of this, or after the life of this hip. So I just had to have it replaced. I had no flexibility. I was in pain constantly. It was bone on bone grinding pain, just terrible. I am overweight. I will be the first one. I'm obese, and that obesity exacerbated the situation. However, it was going to happen anyway. So my treatment was full replacement. For some individuals, they can get pain management and get the joint handled through a steroid injection, and then that gives them some years of relief. But in the long run, more than likely, people will have to have those joints replaced if they, live long enough. All right. The other is osteoporosis, and that is the loss of bone mineral content. The risk factors: race, ethnicity. We also see it with hormonal changes, lack of vitamin D. How do we handle that with treatments? We might have some resistance training, resistance exercises that will help with osteoporosis, nutritional supplements, as well as medications. With diabetes, we obviously know that there are 2 types of diabetes. Type 1 is child onset, type 2 adult onset. Type 2 adult onset diabetes does not necessarily mean that it only happens when you're an adult. It can happen when an individual is a child. We are starting to see more type 2 diabetic children, which is very concerning. And that is due to lack of diet or lack of good diet, lack of exercise, and those are all issues that should be addressed on a different level, on the pediatric level. Type 2 diabetes is when an individual has a pancreas that's not producing the correct amount of insulin, or it's not producing insulin at all. Or it produces, insulin at strange times, okay? The body's tissues are having a hard time responding to that. And so then that's when we see that insulin resistance. And what then happens is that glucose does not go to where it should, and then it just builds up in the blood. Hypoglycemia happens when insulin has an increase. Hyperglycemia happens when our levels become, hypo is low blood sugar, hyper is high blood sugar, okay? So hypo is when, if you have low blood sugar, there are certain numbers. For those of you who have experience with type 2 diabetes, know this much better than I do. But with the numbers with hypoglycemia, there's a certain range that you should be within, and then a certain range you should be within as far as hyperglycemia is concerned. All right. Prevention and treatment of diabetes, exercise and weight control, diet and exercise, and control of our glucose, as well as our blood pressure. High blood pressure and diabetes sometimes go a little bit hand in hand, unfortunately. So we have to pay attention to one and pay attention to the other as well. Need to test, all right, to prevent us from going into a low or a high blood sugar situation. Frequent testing occurs in a number of ways. Excuse me. There are strides being made in testing blood sugar, where it's not the finger prick anymore. It is a meter that sits on the skin that takes those levels at intermittent times and then alerts. Diet and exercise might be sufficient. There are individuals who are diet regulated, type 2 diabetic, and when they are diet regulated, they have figured out the foods they can and the foods they can't eat, and what would cause them to either go hypo or hyperglycemic. Otherwise, if they cannot control it by diet and exercise, then that's when oral medications or insulin are required. Respiratory diseases, a lot of times with older adults, you'll hear of COPD, and that's chronic obstructive pulmonary disease. And it can come in two different forms. One is chronic emphysema, and the other one is chronic bronchitis. Smoking typically is the main cause for COPD. What happens with emphysema is there's a loss of elasticity in the alveoli and the lungs, and then in bronchitis, it is an inflammation and irritation in the bronchial tubes. People who have chronic bronchitis can be deemed a sufferer of COPD. So if you hear somebody say, well, I've got bronchitis again, then more than likely they may be diagnosed with COPD on down the road. Emphysema, as far as the cause of emphysema, that's where that smoking is the main cause is actually linked to. So, whoops, I guess I can't edit that. Yep, going the wrong way. There we go. What will be interesting is with this little realm, how COVID is going to affect it. Okay. Yeah, we just don't know enough. We really don't know anything about COVID. Okay. So the components of COPD, here we see with emphysema is loss of elasticity in there, and then bronchitis, the bronchial tubes being inflamed. Okay. The treatment, frequent testing. Oh, hi. Yeah, that's dumb. I forgot that I did that. Don't pay attention to this box down here because that's obviously for diabetes. So do. Let's just get rid of this whole thing. There we go. She doesn't exist anymore. All right. Hey, what's life unless you have cut and paste? Okay. Or just cut. All right. So as we said, this is just the same thing as was on that other form or other slide. Happy fingers over here. Okay. And as I said, we were going to talk about Alzheimer's disease. I don't really spend too much time talking about AD in this class. I talk about it and other dementias in my other class, Psychology of Aging, but we do get a little bit of an introduction here. Alzheimer's disease, the prevalence of it is about 5 to 8% of the 65 and over population. That's according to the World Health Organization. About 11% of the United States based on by the Alzheimer's Association. So 5 to 8% is going to be a global. 11, oh, for Pete's sake, I'm going to stop touching this stuff. 5 to 8% is global. 11% is just the United States. But some say that might be an overestimate, okay? We do not know everybody who has Alzheimer's disease. Some Alzheimer's disease goes undetected. Some of it goes detected, but is labeled as a different dementia. Some of it is so quick that it's believed that maybe they had Alzheimer's disease, but they succumb so quickly then, or it could be a comorbidity. They could pass away from COPD, but also have Alzheimer's. So it's just a number of different factors that fall within this 11%. The figures may be accurate for all forms of dementia, but not just Alzheimer's alone, because the only time that we know that somebody has Alzheimer's disease is if we do an autopsy of the brain, and not everybody has an autopsy. Okay. The stages of Alzheimer's disease, early, which is mild, middle, moderate, late is severe. early, problems coming up with the right word or name. This is not tip of the tongue. This means it's a word that I've used or a name of a person that I know, and I just cannot come up with that word. Trouble remembering names when introduced to new people. Now, I have this problem. Okay. All right, I'm going to use this as an example. I just watched Hamilton. Okay. I just watched Hamilton, finished it up yesterday. I am absolutely obsessed with Jonathan Groff now. If you have not seen Hamilton, just look up Jonathan Groff. He is the voice of Kristoff in Frozen. He is King George in Hamilton. He is phenomenal. I love him. But for some reason, because I know he plays King George, I keep calling him George Groff. All right. Now, whether that is me not remembering his name or just because I know he played King George and I keep calling him George Groff, I don't know. Maybe that's what it is. But it's kind of like a little block in my mind. But this is, I've introduced you and I cannot remember your name. You tell me your name's Amy, and then 2 seconds later, I forget. That can be just forgetfulness. That could be just a situation. If it happens over and over and over again, then that's when we start looking at this being the reason. Okay. Here, having greater difficulty performing tasks, either in your social or your work settings, forgetting material that you just read, your students, you know what it's like when you cram and you try to cram too much information in your brain. Well, if your brain is having a hard time and has a disease going on with it, imagine what that's like. Losing or misplacing a valuable object or increased trouble with planning or organizing. Middle or moderate, forgetfulness of events about one's own personal history. So forgetting that you got married, or forgetting when your wedding anniversary is, or when the birth of your first child was. Confusion about where they are or what day it is. They need help choosing proper clothing for the season or for the occasion. They may come out dressed in a pair of shorts and a t-shirt and they were supposed to be going to a wedding. Well, is that how you're supposed to be dressing for that? Or should you be dressed a little bit nicer? Changes in sleep patterns. So just as I said in chapter 4, that with sleep issues, Alzheimer's disease is a problem with our sleep patterns. And that is already hitting that middle or moderate stage. So they're sleeping during the day and becoming restless at night. We call that sundowning. An increased risk of wandering and becoming lost. If you have never seen some kind of a bulletin out for an older adult who has become lost and disoriented and the family can't find them and they have dementia, then you have led a very wonderful life to know that does not, to not know of that, but it does exist. Personality and behavioral changes, including delusions or compulsive hand motions. So you might see the individual flapping their hands, both at this, flapping both hands at the same time or something to that effect. And then our severe, which is late stage Alzheimer's, they have to have full-time assistance with daily care. They have lost awareness of recent experiences and surroundings. They have a change in their physical ability. They can't walk anymore. They can't sit. And then eventually they cannot swallow. And then they also have a very difficult time communicating, where they get to the point where they are no longer communicative. There are biological changes that occur in Alzheimer's disease. We have the development of plaques and the development of tangles. This involves the tau protein with the amyloid plaques. Plaques and tangles look completely different in the brain. And so that's why I say that if there's a biopsy of the brain or an autopsy, they can see the development of those plaques and tangles, and that's pretty much the marker for Alzheimer's disease. There might be the reasons behind it, could be genetic abnormalities, the APOE gene, but there are so many others. There could be environmental contributions. Exercise, mental and physical exercise can help, or lack of, I should say, might be a cause, but we don't know exactly, just as much as we don't know about COVID. So these are those plaques and tangles. So there's a plaque, these are the tangles, and this is what forms in that otherwise healthy brain. And then these are the markers that they will pay attention to when they are looking at whether this individual had developed Alzheimer's disease or not. Okay, so this is just what the tangle looks like. Just looks like a clump of tau proteins, and it's just these markers that they pay attention to. All right, so what are some of the risk factors for late onset forms of dementia, including Alzheimer's disease? So a word of caution, not all dementia is Alzheimer's disease, but all Alzheimer's disease is dementia. Okay, so every Alzheimer's disease patient has dementia, but not all patients who have dementia have Alzheimer's disease. So don't ever use these two terms interchangeably, ever. Okay, all right. Age is a risk factor. It's the number one risk factor for developing dementia, or for developing dementia, including Alzheimer's disease. APOE gene for Alzheimer's disease especially, or other genes, cardiovascular and cerebrovascular disease, if we have a high BMI or if we have high cholesterol, our lifestyle, smoking, drinking more alcohol than we should, having a high fat diet, other conditions, depression, brain injury, a TBI, where we have seen, if you've never watched the movie called Concussion with Will Smith, it talks a lot about that with dementia. It mimics Alzheimer's disease, but it's completely different than Alzheimer's disease. They're not identified as being as having Alzheimer's disease. They're identified as having a traumatic brain injury, but it could be inducing a dementia. Having occupational exposure to heavy metals, infectious agents. There could be certain viruses that cause dementia. Genetic, okay, so the protective factors, meaning if we don't have the genetics, if we don't have this APOE gene, APOE4, excuse me, or other genetic predispositions, then we have good genes, and that's a protective factor. We also have some psychosocial protective factors. If I have a higher education and a higher socioeconomic status, I'm able to get to the doctor and I'm able to get those preventions, and I might be able to get on medication a lot sooner than an individual who doesn't have access to that because they are of a lower socioeconomic status. My higher education allows me to use my brain a little bit differently and a little bit later in my life than, say, if I was an individual who just had a less than high school education. If I have a high level of complexity at work, I'm using my brain all the time in different areas and in different manners. I'm not just doing the same thing over and over and over and over again. I might have a rich social network and engagement. So this is going to be interesting, isn't it? With COVID and social isolation, especially with older adults. Social isolation has been a problem with older adults for years and years and years and years. And now all of a sudden, everybody's talking about social isolation because they're being socially isolated. They're in quarantine. They're in their house and not able to do what they want to do. And now all of a sudden we're like, oh, crap. Yeah, old people too. Wow. If I have a very rich social network and a rich social network of and engagement, then I'm talking to people, I'm interacting with them. And we know that's one of the things that the Department of Education has been saying. We need to get these kids back into school because they need to be with one another. They need to have that social network. They need to have that engagement. They need to be able to have that to be able to develop in their brain and socially and physically and mentally and emotionally, okay? Mentally stimulating activities as well are protective factors. Our lifestyle, if we're physically active, if we, the Mediterranean diet, I think I talked about that earlier. Maybe I talked about it with somebody's answer. With the Mediterranean diet, talking about, I think I talked to somebody about the blue zones. I'm pretty sure I did. Fish high in omega-3, which is that goes hand in hand with that Mediterranean diet. Vitamins or foods that are high in A, C, and E, vitamin D, drugs, okay, statins, hormone replacement therapy. They've been finding that, hormone replacement therapy has been beneficial and is a protective factor, as well as NSAIDs. You know, with all my ibuprofen taking, maybe I'm in one of those protective factor situations. All right. Medical treatments, these are just, for those of you who are in pharmacy, y'all know more about this stuff than I do. So, but these are the, that's the generic, that's the brand name, Aricept, Exelon, Namenda, those types of things. And then we also need to pay attention to the caregivers because there are going to be very large burdens on those caregivers. We need to give them psychosocial help as well. We need to reduce their caregiver burden. We need to teach some behavioral methods. So for example, if we know that grandpa likes to, or sundowns, if he starts becoming agitated, we need to figure out things for him to do that is going to modify that behavior and try to reduce that agitation, as opposed to saying, oh, well, it's the AD, he's just restless, just let him walk around the house. I've had individuals say to me that their loved ones will not settle down whatsoever. They don't know what to do with them, that they think that they need to be somewhere. I need to be here. I need to be here. I need to be here. Behavioral modification, just trying to figure out, or some kind of behavioral method to address that, will help both the caregiver and the individual receiving the care. Adhering to a schedule is also very important. If you are loosey-goosey with dinner time and you have a loved one who has AD or dementia, and they know that if that clock says 5:00 and I'm supposed to be eating, then I better be eating. And if I have loosey-goosey dinner times, I probably should stop being so loosey-goosey with it, okay? You will have individuals who will constantly ask, is it dinner time? Is it dinner time? When's the next time to eat? When am I eating next? They're very schedule oriented. And no matter how many times you tell them, they may forget that you told them. Just keep repeating. Dinner's at 5. Dinner's at 5. Dinner's at 5. No, you haven't eaten yet, but you'll be eating soon. Oh no, you've already eaten dinner. Okay. And also targeting those problematic behaviors and trying to figure out what is the issue behind it. Okay. How to diagnose neurocognitive disorders. We have to have a memory problem, which is a progressive decline in our memory. And we also have to have one of these factors, either aphasia, apraxia, or apraxia, agnosia. So aphasia is going to be not able to talk or losing words. Also not being able to have any kind of coordinated movement, or not being able to recognize familiar objects. So I hold up a spoon and I say, what is this? And the person sits there and struggles to even think of the word spoon. Okay. That could be the loss of language ability, but it could also be the loss of ability to recognize those familiar objects. So, okay. Here we go. I don't think that there is much more. Yep. Nope. Just 2 more. Just 2 more after this. Okay. Other forms of neurocognitive disorders, we can have a vascular disorder, could be damage to the arteries of the brain, could be multi-infarct dementia. We also have FTD, a frontotemporal lobe dementia. This is where we would see more personality changes or a loss of self-care. You start to see some self-neglect, and it could be due to that. Parkinson's disease, there can be a Parkinson's dementia that develops with the disease, or Lewy body dementia, which develops with Parkinson's disease. And this is where we start to see motor disturbances or tremors in the hands. And then, as I said before, a neurocognitive disorder with Lewy body dementia. This is a progressive loss of cognition, and it also includes hallucinations and confusion. You may see some hallucinations and confusion with Alzheimer's disease as well. But for the most part, it just depends on where in the brain the dementia is occurring. It is really where it all boils down to. And then we have, I don't like to use the word reversible too much, but there are some dementia or disorders that can be addressed and taken care of, or it takes care of itself. So like a subdural hematoma, that means a bruise or blood on the brain. A delirium, which can be caused by a urinary tract infection or some other type of infection, or a delirium that is caused by an excessive buildup of ammonia in the body. Maybe the liver is not functioning correctly, or maybe the person's constipated. It's just a number of things. Polypharmacy, that is just, some medications that could be causing some of the issues. And then some other things, pseudo dementia. It looks like dementia, it smells like dementia, it talks like dementia, but it's not dementia. Okay. So yeah, that's it for chapter 5. So let me go ahead and we will pull up your assignment for chapter 5. No, not on the rubrics. All right. Hi there again. Okay. So chapter 5 is a discussion board. So there's no Flipgrid. Oh no, there is a Flipgrid. I lied. You'll see that in just a second. Okay. So chapter 5 is a discussion board. Some scientists who conduct research on Alzheimer's disease argue that the newly revised prevalence figures, which estimate that 2 rather than 4 million adults have the disease. So this is that whole 11% thing, okay? Rather that 2 than 4 million adults have the disease will lead to an underserving of the older adult population. Why should we worry about the number being lowered? Isn't that a good thing? Okay. So basically, if the Alzheimer's Association is over-reporting, and actually we have lower numbers than of people who have the disease, so maybe it's 2 million, not 4 million adults, then that can lead to an underserving of the older adult population. Why do you think that we should worry about that number being lowered? Because really saying it's a lower number of Alzheimer's disease individuals is better, right? But what if it's underserving them? Okay, so think about that. So once you've responded with your answer, you're going to respond to at least two other people, okay? And 2 other people, so you're not going to see anybody's posts until you post your response, okay? So you need to post your reply, and then you'll start to see individuals' responses or come up. And you just need to respond, okay? Responses, I would like to see in the form of some thought behind it, not, oh, hey, yeah, I agree with you. Yeah, well, what do you agree with them? If you want to agree with them, say why. Say something in addition to what they said. I agree with what you say, because when I was thinking about it, it was blah, 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 blah. Or no, I totally don't agree with that because blah, 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 okay? Answer the question, or you make your statement and then you support it, okay? All right, so that is the discussion board. It can be found in discussions, it can be found in the module, so it's found any place, okay? Your last assignment, and I lied, this is the Flipgrid, okay? So I want you to record a video on whether you can think of a time where you personally have used ElderSpeak. This goes back to my discussion in chapter 4 about ElderSpeak and when you, or baby talk, okay? When you talk to Mrs. Johnson like this. How are you today, Mrs. Johnson? Or if we use the word sweetie when we come into a patient's room, how are you doing today, sweetie? I want you to pay attention to your environment. If you're out shopping, if you are, of course, I know that with this day and age of COVID, think about if it's not necessarily now, if this is something you've seen, or if this is maybe something you've done, or you've seen done to a family member, okay? So if you've used ElderSpeak or if you've seen ElderSpeak used, it can be any situation at the grocery, at a doctor's office, at the pharmacy, at home. I just want you to record your experience. Please don't name any names or use any locations, just speak in generic terms. So at a doctor's appointment, I saw this happen with my grandmother, as opposed to, well, when Dr. Williams was, she was in Dr. Williams' office here in Findlay, I saw this happen with my grandmother, okay? Don't name names, don't name offices if it's there, or don't name pharmacies. So yeah, while you don't need to respond to another student on this assignment, I do want you to watch another person's video, okay? So, but that's not a requirement. It's just nice to do so, okay? And then once you have completed that assignment, just like you've done with any other Flipgrid, come back to this assignment and say, I've completed it, okay? I think that's it. I am done talking for the day. I've been talking for at least 2 hours straight. Okay. So if you have any questions, don't hesitate to ask me. And if you need anything, I am out of commission all day tomorrow from 9 until 5. I've got Title IX training. But I'm available after that and up until Thursday, until the next module opens. So I think that's it. Okay. Hope you all have a good day. And don't hesitate. I'm looking for my end button. Don't hesitate to reach out and ask me if you have any questions. Thanks.